Hello, everyone. I'm very happy to welcome you at this Olea Academy webinar with our prestigious guest. Today, I'm very honored to introduce Phillipe Grenier, who is a professor of radiology and acts as an expert consultant in the Department of Clinical Research and Innovation at the Foch Hospital in Suresnes, France. Phillipe Grenier received his medical degree from the School of Medicine at the University of Paris in 1972. Throughout his outstanding career, he held the position of Professor of Radiology at Sorbonne University in Paris, as well as Chairman of the Department of Diagnostic Radiology at Pitié-Salpêtrière Hospital. Pioneer in the diagnostic of chronic airway disease and chronic diffuse infiltrative lung disease using high-resolution CT, Phillipe Grenier is a respected expert in chest imaging and respiratory disease. He authored and co-authored over 250 peer-reviewed scientific papers and more than 50 books or book chapters. He is currently a member of the editorial boards for European Radiology, Journal of Thoracic Imaging and Academic Radiology, and also an active reviewer for European Respiratory Journal, Investigative Radiology, New England Journal of Medicine, Thorax Radiology, and many others. Professor Grenier is a recipient of numerous research grants and prestigious awards for international societies, including the Radiology Society of North America and the European Congress of Radiology. He is also an honorary member of the most prestigious national and international learned societies in radiology in Europe, USA, and Asia. In the past, he served as president of the ECR and of the European Society of Thoracic Imaging, but also as a chairman of the EAR Committee for Subspecialties and president of the prestigious Fleischner Society. I hope you will all enjoy the lecture today, and I encourage you to write down your questions in the chat section throughout the lecture. At the end of this lecture, we will have 10 minutes of questions and answers, and I will read these questions aloud so Professor Grenier can answer each of them. Have a nice session, and now, Professor Grenier, the floor is yours. Thank you very much.
Thank you very much for this nice presentation. Many thanks to Olea Medical for this nice invitation to present my experience of artificial intelligence, a new companion for the chest radiologist. The domain of artificial intelligence used in imaging has been machine learning that is characterized by abilities of computers to learn without prior programming. Deep learning represents the state of the art in the domain of machine learning, while classical machine learning needs a prior selection of features in the images. Deep learning generates itself those features during learning. Radiomics is a type of machine learning in which features are extracted, analyzed, and selected for objectives of classification, quantification, or prognosis, prediction, and which can be associated to deep learning methods. Many AI solutions, particularly those based on deep learning algorithms, have been developed to aid chest radiologists in their interpretation tasks. And first of all, deep learning for chest radiograph diagnosis. Chest radiography remains the first imaging examination performed in both in and out patients presenting chest symptoms. Because of work overload and shortage of experts, solutions for computer-aided reports are needed. That's why deep learning algorithms developed to detect automatically specific abnormalities on chest radiographs are very welcome. In our hospital, we use the QAI algorithm named in France QXR and implemented on the Incepto platform. The solution was trained on a dataset of 2.3 million of chest radiographs. It includes several algorithms. The first allows a triage between normal and abnormal chest radiographs, and the following provide automatic detection and characterization of 12 abnormalities for which sensitivity is 0.92% at least. These abnormalities are classified into 4 categories: lymphoparenchyma, mediastinum, pleura, and other, including detection of tuberculosis. And any abnormality depicted is marked on the chest field in a box in red color. You see an example, a lung nodule depicted in the left lung, and the fibrosis scar in the right apex. After 18 months of experience, we are globally satisfied. There is no false negative in the function of triage between normal and abnormal radiographs. Images and reports are automatically generated and implemented in the PACS and immediately available for the clinicians. AI has also been applied to CT in order to detect, segment, and quantify various chest lesions, particularly pulmonary nodules, pulmonary emboli, and mucoid impactions in the airways of patients with chronic airway disease. These deep learning have also been developed to detect and characterize lung infiltration on CT scans, including emphysema, pneumonia, and lung fibrosis, and also to assess quantitatively the extent of lung disease to improve follow-up evaluation of disease. And finally, to predict outcomes, particularly response to treatment or morbidity and mortality prediction by application of radiomics and deep learning methods on imaging data combined with other omics. The first development has been mainly on pulmonary nodule evaluation and lung cancer CT analysis. Beyond detection, segmentation, and volumetric quantification of lung nodule, radiomics and deep learning have been used to characterize the nodule in terms of tumor aggressiveness, viability, response to chemotherapy, and radiation. It also been used for prognosis estimation in confirmed lung cancers or to estimate the risk of distant metastasis, also used to predict histology and mutational profile of lung tumors. And finally, recently, used in combination with other omics to predict response to immunotherapy in stage 4 metastatic non-small cell lung cancers. Here it is, for example, a study in pulmonary adenocarcinoma appearing as a subsolid nodule. This study included 467 patients, 306 for training, 161 for validation. 64% of these nodules showed EGFR mutation. And the CT-based radiomic signature discriminated between EGFR positive and EGFR negative in the both training and validation cohorts. Deep learning have also been applied in patients with chronic obstructive pulmonary disease, COPD. One study in 2020, the deep learning algorithm was trained to classify pattern of emphysema according to the Fleischner Society criteria. In another study, a deep learning approach using only CT imaging data from a large cohort of smokers identified those who have COPD and predicted who are most likely to have acute respiratory disease events and those with the highest mortality. We see an example of 3 cases with a different degree of severity of emphysema recognized by the algorithm. You have different color in areas of the lung. Each color represents a degree of severity of emphysema, from trace, mild, moderate, confluent, or adverse destructive emphysema. And we see here the Kaplan-Meier survival curves corresponding to the different category of severity of emphysema. Deep learning algorithms have also been applied in fibrotic lung disease. Automatic classification of fibrotic lung disease using deep learning algorithms have been attempted with performances at least equivalent to those of radiology in this study. In other studies, the classifiers developed to assess ILD are based on a 2D patch approach. They are trained on dataset including thousands of annotated patches representative of each case, of each class. We see here an example of different CT images with patches reflecting normal area. This reflecting ground glass, this color for micronodules, this color for consolidation, here reticulation, and here honeycombing. And we see the results of the software segmenting all different types of disease in these patients. So, using such approach, the deep learning classifier achieved a similar accuracy to experts for classifying pulmonary fibrosis into the original 4 categories: certain UIP pattern, probable UIP pattern, or pattern indeterminate for UIP, or CT features more consistent with a non-IPF diagnosis. And you know, this is a classical and typical challenge for a chest radiologist facing a patient with a fibrosing interstitial lung disease. Chassagnon and associates applied deep learning on elastic registration of baseline and 3 months follow-up CT scans in patients with systemic sclerosis for longitudinal assessment of interstitial lung disease. The Jacobian determinant was used to measure the progressive shrinkage of lung parenchyma appearing in brown on fused images. And the deep learning classified depicted morphologic and functional worsening with an accuracy of 80% and 83% respectively. After this non-exhaustive review of research studies for developing AI-based solutions for chest imaging, I would like to illustrate my presentation with 2 AI-based applications developed by Siemens Healthineers and already available in clinical practice. The first concerned the COVID-19 related pneumonia. We know that patients with severe COVID-19 pneumonia tend to have more opacities, and the increase in lung consolidation that occur most often later in the disease tends to be associated with more critical illness. We know also that COVID-19 infection may lead to severe viral pneumonia with critical complications including acute respiratory failure requiring admission in intensive care unit for mechanical ventilation or high flow oxygenation. Among patients hospitalized for COVID-19, 14 to 30% will require admission to an ICU, and 20 to 33% of them will die. So there is a need to identify patients at risk for severe COVID-19 because it's critical in order to deliver proper care and to optimize requirements to limited ICU resources. And this is raising a question: can extent and severity of lung disease at initial CT scan indicate disease stage and predict adverse outcomes? Unfortunately, visual estimation of extent and severity of lung disease based on semi-quantitative scoring system may be a source of variability. The percentage of agreements between, in our experience, the percentage of agreements between radiologists estimates remain less than 60% with kappa value of 0.45 or less. And the same comment concerning the concordances between estimates by the same radiologist. Fortunately, Siemens company developed an AI-driven solution based from a huge data set. They use for training for lung and lobe segmentation, the CT scan publicly available from the LST trial and from the COPD gene cohort. And for training for abnormality, they use 901 CT scan, including CT scan of non-COVID pneumonia, interstitial lung disease, and COVID-19 pneumonias. And the test, for the test, they use 200 CT scan, including 100 COVID-19 and 100 healthy controls. And the abnormalities data came from 4 institutions from different continents to implement heterogeneity in a data set. 1 institution in the US, 1 in Canada, 2 in Europe, Swiss and France, and from France it was Hospital Foch. This algorithm permits to output 2 parameters: extent of all lung opacities, calculated from the percentage of lung volume containing opacities, and extent of consolidation the percentage of lung volume occupied by only consolidation. And this is obtained by thresholding by minus 200 Hounsfield units. But the software first segments automatically the interfaces between the lung and the pleura at the chest wall, at the mediastinum, also the fissures, permitted to calculate the volume of each lobes and calculate the volume of segmented all opacities by red contours and calculate the percentage of lung volume occupied by only consolidation in pink on violet or purple colors here. This software was validated and published in Radiology Artificial Intelligence. So we decided to use this application to quantify on CT scan the extent and severity of lung disease in patients hospitalized for COVID-19 pneumonia in order to predict adverse outcomes. 323 consecutive patients with laboratory confirmed COVID-19 and abnormal CT scans were admitted to hospital between March and December 2020. 36% patients experienced clinical deterioration defined as intensive care unit admission or death. And we see there is a significant difference between the percentage of volume occupied by all opacity and percentage of volume occupied by consolidation in patients with severe outcomes compared with those having no severe outcome. And the area under the curve to predict deterioration or death was 0.70 when using the volume percentage of all opacities and 0.68 when using high densities only. And using the optimal threshold defined by the Uden index permitted to notice that 33% or more of lung volume occupied by lung opacities provided 81 sensitivity and 2% of less of lung volume occupied by consolidation provided an 87% specificity to predict clinical deterioration or death. And we applied a multivariate logistic regression analysis, not only on CT parameters, but also the comorbidities and the biologic marker on inflammation. And this multivariate logistic regression showed that not only the CT parameters remain good predictor of clinical deterioration or death, but also comorbidities, diabetes, heart disease, C-reactive protein level, and neutrophils lymphocytes ratio. There was no significant difference between clinical parameters, laboratory parameters, and quantitative measures for the risk prediction performance, but by associating the three of them, we have an increased significant risk of prediction performance. So both independent and incremental prognostic CT value were demonstrated. The same algorithm was adapted to detect COVID-19 pneumonia and distinguishing it from interstitial lung disease and other pneumonias. Was obtained with deep learning classifier. We see here 0.93 accuracy, the curve in orange here, better than with other methods, and better than visual assessment by radiologists using CoRad. This is a curve in blue here. The second AI solution developed by Siemens is AI Rad Companion Chest CT. We have the privilege to have used the Chest AI Companion since October 2019. This solution provides automatic detection, segmentation, and volumetric quantification of different specific abnormalities. I would like to show you them. First of all, we have the automatic segmentation of the interface between the lung and the pleura, including the fissures, automatic calculation of the volume of each lobe, automatic detection of voxels of emphysema using attenuation threshold at minus 950 Hounsfield unit. We see an example of a moderate centrilobular emphysema in this patient, with the table shows the percentage of volume occupied by an emphysema in each lobes here. The same software detects automatically, segment automatically, the solid pulmonary nodules measuring 6 millimeters or more, corresponding to the definition of actionable lung nodule. And the segmentation is very good. We see in this patient 3 nodules, solid nodules were detected, and we see the measurement, automatic measurement of these nodules, L1, L2, and 3. And there are measurements of the maximum 2D diameters, the maximum 3D diameters, and the calculation of volume in millimeters cube of the nodules. Second, automatic detection and quantification of coronary artery calcifications. The calcifications are segmented, and the volume and calcification are automatically calculated. We see the 3D reconstruction of the heart with the heart volume, and in yellow, the coronary artery calcification, and the volume here, 186.9 millimeters cube. That corresponds to a grade 3 of risk of cardiovascular event between 100 and 500 millimeters cubes. And we see another example with bilateral calcification in the coronary arteries. Is the grade 4 because the calcium volume is 747 millimeter cube in these patients. In the same patient, there is a 3D reconstruction of the thoracic aorta, and in white represent the areas where the calcification are located on the aortic walls. Other measurements, automatic measurement of aortic diameters. We see here 4 images selected and reconstructed strictly perpendicular to the central axis of the vessels. We have here 3, 4, 5, 6, reflecting this level 3, 4, 5, 6. And we see that in the aortic, the ascending aorta, there is an increased diameter of this vessel, and this is a feature of very strict surveillance because it's a beginning of aneurysm of the ascending aorta. We see the results on the table with in orange this abnormality detected here. And the last calculation is automatic labeling of the chest vertebra with automatic detection of collapse of vertebral body by measurement of the anterior, middle, and posterior height of the vertebral bodies, and automatic calculation of the bone density here with the value. And we see in this example here, we have the partial collapse of T11, and we see here an hypodensity on this vertebra. Other example on the right, we have in T8 collapse, partial collapse on anterior and middle part of the vertebra with hypodensity as well. So 17 minutes, after automatic transfer of chest CT images to the cloud, the results are available in the PACS. All these abnormalities detected incidentally may have an impact on the future of our patients. So we recently decided to use Chest AI Rad Companion to set a platform for personalized estimation of respiratory and cardiovascular risk in conjunction with screening for lung cancer using low-dose CT. Actually, in the beginning of 2020, the results of a Nelson trial, randomized Nelson trial, were published, demonstrated after NLST that screening for lung cancer by annual low-dose CT in smokers may reduce significantly the rate of mortality by lung cancer. And they demonstrate as well that the percentage of stage 1 lung cancer, they were higher in the screening group compared to the control group from 88% versus 13%. In addition, in the Nelson trial provided 2% of positive tests with 43.5% of positive predictive value versus 24% and 3.8% in RST, using a better knowledge and identification of benign nodule on CT scans and using volumetric assessment of the nodules. But more interestingly, if you look in the same study, the list of cause of deaths after 10 years follow-up, we see that in total, including screening group and control group, the number of deaths by lung cancer was exactly the same as the number of deaths by cardiovascular disease. And this justifies to reread the recommendations made by Dr. Grenier and Nance in 2018 in the Translational Lung Cancer Research Journal. And these recommendations are mainly four. Coronary calcium is a valuable imaging biomarker for the presence of atherosclerotic disease and the prediction of cardiovascular events. Similar to gated CT scans, non-gated CT may play a comparable role in diagnosis and risk prediction. This has been further carried over to the lung cancer screening population, where increasing quantitative scores are associated with greater cardiac events and cardiac-related death. And finally, lung cancer screening provides a teachable moment for both lung and cardiovascular health and should be considered an important part of the discussion of CT findings with patients. The discovery of emphysema on the CT scans has also an impact on the future of the patient. We know from Lynch and Associates the visual presence and severity of emphysema is associated with significantly increased mortality risk, particularly from the COPD gene study. And there were two studies demonstrated that over time, progression on emphysema as CT and lung function decline in smokers with and those without COPD. But interesting was also to look at the results of the COPD gene cohort, where the investigator redefined the diagnosis of COPD. In this cohort, there was more than 8,700 current and former smokers, and they evaluated the patient at baseline, then 5-year visit, and at 10-year visit. And the features used to define COPD include 4 categories. The first one in smoking history. The others are symptoms, dyspnea and chronic bronchitis, spirometry, FEV1, FEVC ratio, and chest CT, presence of emphysema, air trapping, air wall thickening. And all these patients in the cohort were classified in 4 categories. No COPD, that's only smoking history. Possible COPD, there are an additional category of features, either CT abnormalities or clinical symptoms or spirometric abnormalities. They classified probable COPD patients having 2 abnormalities plus smoking history and the definitive COPD. The 3 categories of anomalies are accompanying the smoking history. But interesting, and you follow the patients over time, and we notice that the patient with probable COPD, either by the combination of imaging features, say clinical symptoms, or due to the presence of abnormal spirometry and imaging features, they have over time a functional decline and increase of all-cause mortality. That's why it deserves to take into consideration patients having a probable COPD. So on the basis of this information, we decided to develop or to offer to former or current smokers of 50 to 80 of age a platform, including smoking cessation program and low-dose chest CT. And using the AI RAD companion algorithm, we detect automatically indeterminate pulmonary nodules. We detect and quantify coronary calcification, and we detect and quantify emphysema. And if indeterminate pulmonary is detected, according to the follow-up, the patient could be resected if necessary. In terms of coronary calcification, grade 3 or 4, the patient is addressed to the cardiologist for stress testing, echocardiography, and CT coronary angiography. And if there is emphysema, we ask for spirometry, and if the patient presents probable or COPD or COPD, addressed to the pulmonologist to get good management in order to avoid acute exacerbations. This is another presentation of our platforms, and we hope that this approach will reduce mortality and morbidity from cardiovascular events and will improve the cost efficiency ratio of CT scans performed to screen for lung cancer. I thank you very much for your attention.
Thank you very much, Professor Grenier, for this outstanding and very didactic presentation. I personally have two questions. The first one is, do you think that the COVID crisis acted as an accelerator to innovation in chest imaging?
The accelerated innovation, yes, definitely. AI will definitely accelerate innovation, particularly in the disease I'm involved in, airway disease and interstitial lung disease. And we are we have a project in Fort Hospital of a big project to combine all the omics on a big cohort of patients with chronic airway disease, including asthma, COPD, obliterative bronchiolitis, and post-transplant BOS, etc. And with the CT data and also functional data, particularly functional data extracted from MRI, and to redefine the phenotypes of this airway disease, because you have to redefine the phenotypes for better new management of these groups of patients. All these diseases were evaluated in silos. We need to redefine totally the definition of these abnormalities by combining, and using AI for that, by combining all the omics, functional, clinical, biological, and imaging.
Thank you very much. And the second question is, how confident can the radiologist be in automatic detection and characterization by AI-based algorithms? In other words, does the radiologist still need to check each scan for confirmation?
Yes.
Have you heard of any experiences with erroneous detection or misdiagnosis due to AI-based algorithm failure? And who's responsible in case of such errors?
This is a crucial question, of course, and a difficult question. Regarding computed tomography applications, the radiologist has to check everything, of course, because the algorithm may provide some mistakes, of course, in segmentation, mistakes in characterization, and so on. But anyway, so the radiologist remains the master. He is using the AI algorithm just to help. He's a second reader with another approach, particularly radiomics. Radiomics is an additional information for the radiologist, because radiologist is unable to extract the information provided by radiomics. Though it's a good combination. Regarding the chest radiography, I must confess that the application you are using at Forge Hospital, the radiologists now have abandoned the interpretation of chest films because the risk of false negative is almost zero. And regarding the abnormality detected, the clinicians, as he's confident with the abnormality detected, no problem. If he's not confident, he asks the radiologist to check the imaging with him, and they discuss. But it's very rare. In the majority of the cases, the clinicians is independent with the chest radiographs. It's not a good thing, but we are missing radiologists, and the radiologists are not at all available to interpret all the chest film in the hospital. So that's why we are confident with this application for chest radiograph. But in practice, when there is abnormality on the chest film, the clinician asks for a CT scan. So the risk is very minimum.
And in case of failure of AI-based algorithms?
In case of failure,
how's the responsibility?
The failure. If in case of a failure and the responsibility in front of the judge.
Who's responsible actually for the error?
The responsible is the physician using it.
Physician.
Absolutely. That's the physician remains responsible. For this CT scan, there's a radiologist as responsible for the chest film, the clinicians using the system with the agreement of radiologists. That maybe both will be responsible.
Thank you very much. It wasn't an easy question. Bye-bye, everyone. And
Bye-bye.
Have a nice evening, afternoon, or morning, wherever you are. Thank you.